بکنیم. Dear my colleagues, tonight we have a presentation of Professor Joe Niamtu from US. It's about the facial implants. This program is offline. He sent us the PowerPoint file with the voice. I hope you can enjoy tonight of this presentation, and after that maybe we can have a small discussion about the benefits and disadvantages of facial implants. Okay.
آقای دکتر حتما این بعدش من اینو طوری تنظیمش کردم که بیشتر از زمان پاورپوینت باشه. حتما اگر همکارای دیگه هم باشن یه بحث و تبادل نظری داشته باشیم روی این کاستوم مید ایمپلنت ها که الان جدیدا دیدم که از جنس سیلیکون هم میسازن به صورت کاستوم که این تا حالا من ندیده بودم که خیلی خوب میشه این برنامه رو داشته باشیم انشالله. خیلی ممنون. شما شروع کنید. فکر کنم پاورپوینتتون رو فقط بذارید رو اسلاید شو.
Hi, I'm Dr. Joe Niamtu, and today I'm going to talk to you about mid-face implants.
صدا آقای دکتر قطع شد.
I want to see if this video works, and I want you to keep an eye on this video. I want you to pick your favorite Rolling Stone and look at them over a 5-decade, 50-year aging situation. So pick one of the Rolling Stones and look at them throughout this video. Here we go. So needless to say, aging happens to all of us, especially rock and rollers. Now, this is a picture of my son when he was younger, of me when I was younger, and my father, who's 27 years older than I am. And you can see the progressive loss of mid-face volume, and our cheeks pretty much disappear as we age. A large part of the cheek volume is the malar fat pad, and the malar fat pad sits in the mid-cheek. It lies against the nasolabial fold, and the apex is at the zygomatic region. And I like to break the cheek into really 3 aspects. Number 1, as you see, is the infraorbital. Number 2 is the malar, and number 3 is the zygomatic. So when I do implants or filler, those are the areas on which we concentrate. And this is a cadaveric specimen of the malar fat pad. And again, the base lies against the nasolabial fold, and that's why as we get ptotic mid-face, we develop bigger nasolabial folds, and then the apex lies over the zygoma. And on the CT scan, you can see that as we age, our cheeks kind of turn into our jowls because we have ptotic tissue and fat that descends to that area. Well, and when they smile, I hold their cheek up and ask them to relax. Now relax. And that shows the augmentation. It also shows when you drop that, the cheek becomes the jowl. Smile. So there's your augmentation. The patient can see that in the mirror. And when they relax, the cheek becomes the jowl. Cheek becomes the jowl. So we want to show them what that looks like to volumize that area and how important mid-face fillers or implants are in the whole perspective of facial rejuvenation. So that previous slide was a good way to explain to patients why they need cheek augmentation. Now, when we do cosmetic surgery, it's really important to put something back, whether it's filler, whether it's implants, whether it's fat. And we know that by doing cosmetic surgery, sometimes patients are made to look tighter but not younger. And just pulling skin over a skeletonized face is not an aesthetic situation. We want them to look younger. So some people love fat, some love fillers, some love mid-face lifts, whatever works well for you. I'm a big proponent of facial implants, and I love cheek implants, and I have them in my own face. So why do I like them? Well, there's no visible scar. Procedure takes about 20 minutes on each side. It can be done under local. You get immediate three-dimensional volume. It's a reversible procedure, but it's permanent. And not many things in cosmetic surgery are reversible, but permanent. So basically, in the normal case, they'll last a lifetime. However, if you want to change them or remove them, that can be done. So these are some of the big reasons I like cheek implants. Implants come in a variety of shapes and sizes and companies, so it's a little bit confusing of what to use where. So here are three different kinds of mid-face volume that we deal with. The patient on the left is your most typical situation where she has that submalar volume loss. So she would need a submalar implant. The patient in the center has pretty good submalar fill, but she could use lateral augmentation. And the patient on the right doesn't have anything, so he would benefit from zones 1, 2, and 3 that I showed you earlier. He needs augmentation everywhere. Now, these are the three implants that I use: the submalar implant, the malar shell implant, and the combined submalar shell. But I will tell you that 99% of my implants are the submalar implant shown on the left. It's an extremely versatile implant, and that is almost exclusively what I use in every patient. So here's a patient that I did upper and lower blepharoplasty. I did a small facelift, and I did cheek implants. And the thing that really sets this post-operative result off is the cheek implants. And if I just did the facelift in the eyelids, this patient would not have had this level of rejuvenation. So it's extremely important to appreciate what cheek implants can do for your case. And again, this is a submalar implant. It's technically a binder submalar implant type 2. And this works well for patients with adequate projection on the lateral cheeks, but they're missing that central, that zone 1 and 2, that infraorbital and malar volume. And that's where this works so well. So if you want to show a patient what they would look like with cheek implants, you can have them lay back supine, put their chin up, and look in the mirror. And gravity repositions the mid-face. And I think this is a pretty accurate way to show a patient what they would look like. One thing you want to pay attention to is the patient's dental, periodontal, and osseous situation. You do not want to put implants in somebody that has active dental or periodontal disease. Also, it's important to do an intraoral examination to make sure there are no cavities or cysts. And I think it's important to do a panoramic X-ray or cone beam scan to make sure that there are no cysts, infections, or other pathology that may complicate your implants. So the procedure is done by putting local anesthesia subperiosteally around the area of the implant, and then injecting a small bit for hemostasis above the canine tooth. And the canine tooth is the third tooth over from either side. And this incision is made in the unattached gingiva, and it's just about a centimeter incision. That shows the incisions. And in terms of instrumentation, these are three very simple instruments that are helpful. Number one is a periosteal elevator. That's called a number 9 periosteal elevator. The upper right is a long, thin tonsil clamp. in the lower right is an Aufrecht nasal retractor, which is a very useful instrument to retract the cheeks. So we make our incision through mucosa and submucosa and through the muscle, and the incision is made all the way to the periosteum. So we're making an incision through the mucosa, through the muscle, all the way down to the periosteum. And the only situation of consequence is the infraorbital nerve, and that's really the only critical anatomy that's involved in this area. So if you're going to do cheek implants, you have to be familiar with the anatomy of the infraorbital nerve. So when we begin our dissection, we put the periosteal elevator in, and we go right to the bone. We want to be subperiosteal, and I will dissect several millimeters superior. And at this point, I need to be cognizant of the infraorbital nerve. And the infraorbital nerve, you usually see this coming out of the infraorbital foramen, and it's usually about 5 to 8 millimeters under the infraorbital rim. And I like to actually expose the nerve so I can see that. So you want to make sure that your periosteal elevation is not going to affect the nerve. So we change the direction to an oblique vector. And now this oblique vector will take us dissecting over the lateral zygomatic region, and I actually dissect up between my thumb and finger, and my finger is protecting the globe, and I will dissect there all the way up to the frontal zygomatic suture. So the implant sits in approximately this position, and you don't want to have a very large pocket on your implant. You want your pocket to be just a little bit bigger than your implant. Otherwise, you will have problems with dead space and possible movement. So the implant, the submalar implant, pretty much sits in this type of position. And for larger implants, you may encounter the masseter tendon, which is attached to the zygomatic arch. And that's not a problem. You don't have to incise this tendon. The implant can lie over the tendon if you happen to see this, and it won't hurt anything. So once I have my dissection completed, I will take my elevator in a sweeping motion just to make sure my pocket is big enough to accept the implant. And again, these are small incisions, but this is very elastic tissue, and so you can get very good access through a small incision. And at this point, I'll irrigate the pocket with antibiotic solution and use a tonsil clamp to place the implant, period. These implants are anatomic. In other words, they are fabricated on human skeletal analogs. So they almost automatically sit where they want to live. They are concave on the bottom, so they will fit on the bone. And again, they slide in pretty easily. You want to make sure that you do not inadvertently fold the tail of the implant over on itself, because that's a problem. The implant won't sit right, won't look right. The patient will feel that. So you want to make sure that the tip of that implant is not bent over. So here's a patient where the implants are placed. And this is an area where some people would just close with sutures, but I always use screw fixation. So after I put the implant in, I'll pull on the lip and press on the cheek to make sure that the implant does not slide out of the incision. If the implant protrudes, then I need to either trim the implant or make the pocket bigger. And one of the nice things about silicone is it's very easy to trim and shape. Now, when I put the first implant in and I'm happy with the position, I will take note of an imaginary line that goes from the medial part of the implant, and I will see where that imaginary line indexes the tooth on that side. So let's say that imaginary line lines up with the first premolar. Well, when I put the implant in on the other side, I will try to make that line up with the first premolar as well. So assuming that the patient has a full complement of teeth, then the medial lateral distance will be the same by trying to index via the tooth position. For the superior-inferior position, I will place the implant at the infraorbital foramen, and when I get the implant secured on one side, I will take note of how far away I am inferior to that foramen. So when I go to the contralateral side, I can again index that to be the same distance away from the foramen. I use 1.8 or 2.0 titanium self-drilling screws. And I like to put my screws in the dense bone, and that's usually either the piriform bone or the buttress bone. You can put these screws in the sinus, but it's not something that I routinely do. I prefer the thicker bone. And I usually put 1 or 2 screws in to hold the implant. Many people place implants and they don't use screws, but I'm a huge proponent of this because I see a lot of patients who present to my office who are treated by another surgeon and their implants have migrated. So I think that placing these micro screws is very important. Now, sometimes the implant will overlie the neurovascular bundle, the infraorbital nerve. And if it does, shown in the upper left image, then we need to make a window to relieve around the nerve, which is shown in the right image. And so I'll take a scalpel and cut out a small window so that the implant does not impinge on the infraorbital neurovascular bundle. That's important because if that implant touches that bundle, the patient will feel a shocking feeling and feel pain. So when you place your implant, there's really 4 things you want to look at. Obviously, the position and the actual size of the implant, but positionally, you want to make sure that the implant does not impinge above the inferior orbital rim. You want to make sure that the tail of the implant is not folded over, and then you have a smooth transition here. And finally, you want to feel up inside the vestibule and make sure that the inferior portion of the implant does not protrude too far inferiorly on the maxilla, where you have a big ridge there that you can feel, because that will bother the patient. Also, it means the implant is not placed high enough. So those are the things, 3 things that you want to look at.
آقای دکتر فکر کنم باید اسلایدتون عوض کنم.
So again, it's important to make sure that your implant does not protrude above the orbital rim, or you'll have a visible and a palpable situation that the patient will be unhappy with, and you'll have to go back and reposition that. Once I put the implants in, I stand behind the patient and try and see if everything is symmetric, which you also, I will take my hands and stretch the cheeks, which gives you a kind of a better view of what the implants look like, because when the cheeks are relaxed, because of the edema and the local anesthesia, it's kind of hard to tell. So We then irrigate with antibiotic solution and close this with fluoro gut dissolvable stitches. I compress this about 5 minutes after surgery from the outside, and also put cheek compression gauze on the inside until the patient goes home. We're placing a small combined submalar implant from Implant Tech, silicone implant. We're injecting 2% xylocaine, 100,000 epinephrine transcutaneously over the malar and submalar regions, and then going intraorally and placing a small amount, just enough for vasoconstriction on the mucosa above the cuspid region. About 6 cc's on each side is what we place total. At this point, then, we will make our incision. The incision is made just about a centimeter above the attached gingiva into the sulcus, above the canine tooth, the third tooth over, and I'm using the Elman radio wave microneedle here, which is generally a pretty bloodless incision, all the way down to periosteum, and that's extremely important. These implants need to be subperiosteal. Now we're taking a periosteal elevator, and our initial dissection is superior, but we have to stop because we don't want to hit the infraorbital nerve. So after about a centimeter of superior dissection, we're going to angle our periosteal elevator now obliquely and dissect in that vector out towards the frontozygomatic suture. So I'm placing a finger to protect the orbit, and my thumb is on the other side of the frontozygomatic region. And depending on the implant, we're generally dissecting out into this region. Again, this has to be subperiosteal. I'm doing a sweeping maneuver now, and what I'm actually doing is expanding the pocket with the periosteal elevator by sweeping it superiorly and inferiorly in an arc motion like this. And so after I do my superior and lateral dissection, I'll do that sweeping dissection as well. Most of these implants will also sit over the masseteric tendon, which we will look at here. You can see the tendon from the masseter muscle, and that's fine for the implant to sit over that. Also, we will sometimes see the infraorbital nerve, which you want to obviously contract, and sometimes you have to relieve the implant if it's impinging on that nerve. I'm irrigating with clindamycin antibiotic solution. We have a tonsil clamp with the left side implant. The implant is placed, and if your pocket is just bigger than the implant, these are anatomic, and they'll kind of auto position on the bone right into the perfect position. Once they're in place, what I like to do is push on the implant, pull down on the lip, and take my palm and push on the implant, then go back in the mouth to see if the implant was extruded. If it's extruded, the pocket's too small or the implant's too big, it needs to be adjusted. Now I'll take a self-drilling screw and place a 6mm screw generally over the thick buttress bone. One single screw just holds the implant in place. I think that's very important. Now I'm lining the superior edge of the implant up, usually between the cuspid and first premolar, and that's an important index to make sure they're both in the same spot. I'm compressing the implant to extrude any blood, and standing behind the patient, looking over their forehead to make sure that we have symmetry. And at this point, if I'm happy with what I'm doing, I place several gut sutures, and I don't want this totally tight, so I do want to allow some drainage. It takes about 10 minutes per side to do these implants with experience, and that's how we do it. So I hope you enjoyed the movie, and these are some before and after pictures, and this patient had some type of facial wasting disease, and implants certainly helped her. This is a doctor that lived in town, and I did cheek and chin implants and really totally changed her profile. Again, look at the cheek implants. You can see where the light reflex is now moved to show the volumization of the cheeks. Here's a patient that I did blepharoplasty, cheek implants, and facelift, and it provides the patient with a much softer appearance. Another patient, facelift and cheek implants. This is a common combination in my office. And again, we're making people look younger, not just tighter. This is a patient with very flat cheeks before and after cheek implants. This is facelift, brow lift, laser, cheek implants, chin implants. So look at the mid face on this patient who's almost 70 years old. She looks much younger because of her cheeks. Same thing. This is a blepharoplasty, cheek implants, facelift. Chin implant, cheek implants, facelift. Again, and this is an older case of mine, but brow lift, cheek implants, chin implant, facelift, laser resurfacing. This is just a combined submalar shell implant, giving volume to the shell. And that is my lecture. I hope you enjoyed that. I wish I could be in St. Petersburg, Russia right now, drinking vodka with all of you. And I hope that you enjoyed the lecture. I want to come back when the virus goes away. Do svidaniya.
Thank you. These are all his clinics and congress he have joined. Hi, Dr. Kheli Mamnoon. It is very good, very nice. And any of our friends from the abroad, if they have any question or if they want to have any discussion, please start, and you can also unmute your microphone and talk. Or if you can write also your question in the chat box.
Okay, it seems that none of our colleagues wants to speak. Let us start, Dr. Nawab. What's your idea about the facial implants? Can you compare them with osteotomy techniques in the face? For example, for cheek or chin implants instead of genioplasty or malar osteotomy?
Dear Dr. Parhis, yes, I actually started cheek implant long time ago. If you remember, long time ago, there was one kind of implant, cheek implant, Gore-Tex. At that one, I was not a very good result for that. But for the parhis, I got a very good result. And I have so many patients for more than 10, 15 years, which I am following. But the silicone, I don't have. Whatever it is Dr. Niamtu is doing, he is using one special kind. If you have his book, in his book, he got few recorded video.
Like Nawab. Okay. Dr. Nawab. Dr. Nawab, welcome again. Dr. Nawab, unmute کنید. Mute هستید.
Now is okay?
Yeah, it's okay.
I was talking about the facial implant in the temporal region. For the first time I was seeing, and it is not available in our country. That is the problem, Dr. Parhis. What is your idea regarding the custom-made implant?
Yeah.
Now I think in Iran is available.
Let's start with the previous kind of implants, Gore-Tex, parhis, silicone in the face. To be honest, I don't agree with facial implants, especially in malar and chin area. because we can do malar osteotomy or genioplasty instead of facial implants. I think that disadvantages of osteotomy is less than facial implants. Risk of infection, displacement, and malformation after facial implants, I think that is much more than osteotomy techniques. Of course, in osteotomy techniques, it's very dependent on the skill of the surgeon, especially in the malar osteotomy. What about custom-made implants? Okay, I agree with them, especially in patients who we cannot do any other, we don't have any other options. For example, in old malar fractures, in old zygomatic fractures, which we cannot do malar osteotomy, or in patient we have comminuted fracture in zygomatic area. Okay, in that situation, we have to place facial implants, and of course, custom-made implants is much more better.
Yes, I also agree with you, doctor. But I am also agree with you regarding the osteotomy, because in your hand, and it can be permanent. And if you remember, we have seen in last few years a lot of cases of a parhis implant in the chin, which caused resorption of the bone, and supposed to be removed. One of our friends asked a question regarding trimming of silicone implant and fixation with the screw. This is a controversy. Some people, even parhis also, we have to trim it. It is always not, it cannot be fit according what you want. You have to trim it and make it in one size on both sides. And once it's equal, you can place it. You cannot place once and fix and then trim the other one. Before you put in the place, you have to trim this, and then you can fix it. Otherwise, won't be imbalance. One side may be a little bit higher on the other side. And regarding the trimming, silicone is very easy to trim, but in the parhis, you have to use the knife to trim, and it's a little bit difficult. Some people, they used to put in the warm water to become a little bit softer, or antibiotic solution, and then trim it. Regarding fixation, I have got a very bad result of suturing and putting in the very good pocket. It will come out. It will come out and cause a lot of problem. It's better to fix either with a screw or something else. What about your idea, Dr. Parhis?
Yes, right. It's correct, doctor. For trimming of silicone, we have to use just knife and scissor. But other processes like that, Gore-Tex and parhis, you can trim them with the burr. But for the silicone, just scissor and knife. And also, I have to say that the trend is changed, of course, especially among maxillofacial surgeons. Most of them believe that osteotomy techniques is much more better, much more predictable, and permanent than other techniques. But most of plastic surgeons are interested in facial implants. Okay.
They are not very familiar with the bones of the face.
No.
Another question from Dr. Abbasi is written: how you are analyze the malar region? Do you use any specific software or not? Some people, they are using software, but there is a trick kind of different kind of this parhis and silicone on 2 millimeter, 3 millimeter, 6 millimeter, and 5 millimeter, and 7 millimeter. You can put on the patient face, and according to that, if it is agree, you can select it. Or if you are able to have a materialist or dolphin, you can use a software to do that. But that is good for the custom made, not for the ready-made implant.
And also, I have to answer my friend, Dr. Abbasi. I know that you know better than me. We usually judge about need to do malar osteotomy or using facial implants in the cheek according to the clinic of the patient. I mean that there are some criteria that show us there is some deficiency in the midface and in the zygomatic area. For example, a scleral show that the middle one-third and the midface is deficient. Another thing that is the transverse dimension in the zygomatic area according to the angles. It also shows us that we need some augmentation in the malar area and also some depression in the submalar area. Of course, you know that better than me, but I don't think that software can help us much more. I prefer to judge according to the face of the patient.
There is Dr. another question from Dr. Kayvan. He's written if any colleagues have experience about the silicone malar implant and if there is a bone resorption. I have not seen with the silicone, but I have seen a lot with the porhis. I don't know what about you, Dr. Parhis. Have you seen or any other colleagues if have experience regarding silicone causing resorption?
Fortunately, I don't have any experiences with silicone implants, but I think that one of the most concerning items about silicone implants is that if you want to trim them and if you want to screw them in the area, some small particles of them can cause irritation and inflammation in that area forever. And mostly I have heard that, but I don't have any experience about that. After a while, we have to remove them because of local irritation, some redness, and sometimes in inflation and inflammation in the area. But I don't have any experience by myself.
Dear Dr. Parhis and other colleagues, I wanted to share my screen and show you one university, American College of Oral and Maxillofacial Surgery. If you participate, if you joined, you can have so many classes regarding facial cosmetic and orthodontic surgery. But this is here, there is a course. And in few days also they have another course coming. You can have aesthetic, you complication in oral maxillofacial, craniofacial, and facial cosmetic. In facial cosmetic کجا امریکا و خیلی راحت شما میتونید ریجستر بشید و برنامه‌های خیلی خوبی هم داره تو تمام زمینه‌های فک و صورت.
آقای دکتر اگر میشه لینکش رو بذارید توی گروهمون.
باشه لینک من میفرستم براتون که برید.
اوکی.
آقای دکتر حالا تا اینجا هستن حدود 27 نفر. اگر برنامه‌ای هم خواستیم همین برنامه نیاماتو، همین آقای دکتر کی بود که 2 سال پیش برامون یک وبینار فرستاد توی کنگره‌ای که شما بودید با دکتر کیان، یادتونه؟ دکتر فتاحی نه؟
بله.
ایشون هم توی این کنگره جدید انوال میتینگی که مال امریکا بود و اول اکتبر تا 10 اکتبر برگزار شد. اونا لینکش رو برای من فرستادن، منتها از طریق زوم میتونم باز کنم، یکی دوتا از کلاساشو نشون بدم. اگر کسی علاقه داشت از رزیدنت ها میتونید بعداً بگید که میتونیم بیام پخش کنیم، چون اونم آفلاینه دیگه.
بسیار بسیار.
اگر سوالی نیست دیگه خداحافظی کنیم خدمت همه عزیزان. اگر سوالی چیزی هست.
Hello colleagues, excuse me, I don't know if I can speak English or Persian.
No, yes, English, very good.
Thank you. So I wanted to know if there is a record of these webinars available in anywhere we can use it.
Yes, I will send you the link through the YouTube. I have recorded, it is live in YouTube. If you
Because we
Wait
have
for-
another webinar with Dr. Najmi about blepharoplasty. I missed it. I
Yes,
missed it.
that one also is available. I have to trim it. It is already on YouTube. This one is not completed, but I will copy the stream link. Yes,
Thank you.
I will put in the chat. You can
Thank you.
use this one.
Okay, sure.
Yeah, I have sent it. I have sent it to everybody. You can use it. And Dr. Najmi also is available, but Dr. Najmi, because of some problem of the internet, it is not trimmed. I will trim it in a few days and let you know. That one also, you can find it in this link. Thank you so much.
Thank you very much.
You're welcome. Anybody else got any question?
Thank you.
همه دیگه خدا
Thank you, Nawab.
قربان شما خداحافظ شبتون بخیر تا 27 ماه دکتر 27 ان